All right, this is amazing. Good morning, good afternoon, good evening, wherever you might be. My name is Key Park. I'm the Director of Policy and Advocacy at the program in Global Surgery and Social Change at Harvard Medical School. Welcome and thank you for taking the time to join us. We have an amazing program today. Our program is titled The Political Argument for Equitable Surgical Care. It's a conversation with champions and experts. There's a saying that health is inherently political. And this is absolutely true in global health. So we have two separate panels. One is champions. We'll hear their political arguments and their perspectives on their particular area of expertise. But the second panel, which will start at 10 a.m. Boston time, involves people that have a higher vision, a higher level of perspective, whether WHO, global health, academia, publications, even diplomats and ministers. So we'll get a kind of a critique on how we're doing and making this argument. So this will be a really interesting session. We hope to come away with some pearls that we might be able to do something to advocate for surgical care in a better way after this session. So I'm delighted to introduce my co-moderator, Gail Rousseau. She's the chair of the board of the G4 Alliance. This is a collaboration between CUGH, G4, and PGSSC. Gail, over to you.
Oh, thanks very much. It's a pleasure to be with you, Key, with Keith Martin, who chairs the CUGH, and with all of our champions and experts today. As Key said, I'm also a neurosurgeon at George Washington University. I chair the board of directors here of the G4 Alliance, and I've served in a variety of positions in neurosurgery on a global level. And it is my really deep honor and pleasure to introduce to you this outstanding panel. In the coming hour, we'll hear from each of them and hear, as Key said, their arguments from the front lines for the political case for advocating for the neglected surgical patient. And at the G4 Alliance, that's what we're all about. We are G4, as you probably know, stands for the 4 groups that work together because we need the same infrastructure in order to help our patients improve their health. So it's surgery, obstetrics, trauma and anesthesia care. We're a federation of over 75 member organizations representing civil society, professional societies, academic university centers, and NGOs. So we are happy to have been called the home for global surgery and want to rise to that occasion and fill that mission and that space in the global civil and political world. So let's get started. We're going to hear advocacy for global surgery from various specialties. This is our outstanding panel, all of whom represent member organizations of the G4 Alliance, who will be, from their perspective as frontline healthcare workers, be making the case, the political case, for why government should invest in healthcare for their people. So let's start right off. Our first speaker is John Sampson. Dr. Sampson is Associate Professor of Anesthesiology at Johns Hopkins, where he is the Director of Anesthesia for the Johns Hopkins Global Alliance of Perioperative Professionals. I'm delighted and proud that he's a member of our board of directors at the G4 Alliance, and John has had a career which is dedicated to promoting excellence in anesthesia and critical care, and also is a real expert at working together collaboratively in the global surgery space. So without further ado, let me give you John Sampson, who will give us his opening remarks about this very important topic. Dr. Sampson.
Good morning, everybody. Glad to greet you here from Baltimore, Maryland. I'll be sharing my screen here just to have a little bit of visual aids as well. And I'm assuming everyone can, let me see. Okay, good. All right. So what I'm going to be talking about is the importance of collaborating with government to improve anesthesia training, education, and medical supply. But I actually believe that this applies to all aspects of global perioperative care, as well as global health as well. Our group makes this a practice for all of our projects. We endeavor to collaborate with the stakeholders, the government stakeholders. Right now, we're doing a very large project with the Society of Critical Care Medicine. It's a 2-year project, and it covers 4 different countries: Ghana, the Gambia, Liberia, and Sierra Leone. And as part of this, as I'm going to explain, we collaborate not only with each of those governments, but also with the regional governmental organizations that cover the West African region, as well as Africa as an entire entity. Okay. In order to have health system strengthening, you have to engage the health system. So you're not really going to strengthen the health system, the health system, unless it's engaged with, and that includes both clinical activity, advocacy, and also research. And one of the advantages that our group does have is that our group has attracted a large number of people from the African diaspora, not just African Americans, but people who are from Sierra Leone, Liberia, Ghana, Nigeria, Ethiopia, and other locations as well. And sometimes they bring with them connections to the government entities that we need to connect with. Some of the benefits are that you end up now creating other partnerships where you can actually connect with students and young researchers in the countries that you're working with, and you can develop them and partner with them so that they can also improve their skills and capabilities. From one of our projects in Sierra Leone that was prior to the Ebola pandemic, every one of the people on the left who we had trained in basic research techniques for studying the perioperative environment in Sierra Leone over 3 years, each one of them then got public health jobs within the Ebola response system during that pandemic, and ended up being assets to the recovery from that pandemic, as well as developing their own careers. As part of that, also, the government ended up, as a result of the research that we did, ended up identifying a more cost-efficient way of obtaining anesthesia machines, and then was able to get 41 anesthesia machines to distribute throughout the entire country. These are some of the entities that we collaborate with, but they are not necessarily government entities. And then when we get to the government entities, we have, for our current project, just for the current project we're doing, we partner with the Liberian Ministry of Health. We actually went to Africa Climate Week, to the UN Climate Summit this year in September, and the Minister of Health of Liberia was literally one of our teams, flew down there and spent several days with us advocating for changes and improvements in oxygen access hospitals in West Africa, as well as advocating for climate-friendly, energy-efficient ways of delivering oxygen. Her voice was very influential to people throughout the climate summit, and she ended up being asked many times during the climate summit to unofficially talk about what was happening in her country. So she ended up being a very powerful advocate. We're also collaborating currently with the Ministry of Health of Gambia, and that has connected us to the First Lady of Gambia, and the two of them have been a very powerful advocate for environmentally friendly and energy efficient ways of delivering oxygen and renewable energy for hospitals. And then also a representative from the Ghana Health Service also came with us to Africa Climate Summit. So if we weren't collaborating with these people on the ground for our projects, not only would our projects not be synchronized with the national health priorities of the country, but also we wouldn't have had this great international advocate at the United Nations Africa Climate Summit. But we don't stop there. We also think that it's important to actually collaborate with the regional authorities as well. And so on the bottom, you have the symbol for the Economic Community of West African States, known as ECOWAS. And CEDERO is the French version, just a French translation of that. And it represents 15 countries within the political sphere of West Africa. And so by having them as a partner, a literal partner on our current project, then we're able to get the word out to people within the entire African region. We're able to actually promote biomedical engineering and a culture of maintenance for the type of equipment that we're installing for oxygen and renewable energy throughout the entire 15 state region. And in addition to that, we collaborate with the Diaspora Africa Forum, which is on the top picture, and they are part of the political force that works with the Africa Union, covering all of Africa, to have the African diaspora be considered a sixth region of the Africa Union. So therefore, even as far as the president of the Africa Union and the Africa Union's medical arm is aware of what we're doing and is there to support us as might be needed. So fringe benefits from collaborating with government entities, or when there's a crisis that affects the government, like the Ebola pandemic, then we're able to actually be connectable. They know who to connect with. So during the COVID pandemic, the Sierra Leone presidential office created a presidential initiative to respond to that. And that presidential initiative also reached out to our group, which was able to respond and provide tele-education directed medical simulation training on mechanical ventilation to doctors and nurses throughout the entire country of Sierra Leone in real time at the beginning of the pandemic during April, May, and June of 2020. And we wouldn't have been able to, they wouldn't have known who to connect with, and we wouldn't have been able to connect with them for that response if we had not fostered that relationship. And finally, by collaborating with government entities, then it syncs with other things. This ship, European ship that you see on the left, is anchored off the coast of Sierra Leone, providing energy to shore up energy problems with their power grid. And there's other ships that are anchored off of several other West African countries. But one of the things that we're trying to do is create more renewable energy opportunities for healthcare centers. And in order to do that, we do need to interface with both the Ministry of Finance and the Ministry of Energy. Well, our conduit to them is the Ministry of Health. And so those are the reasons why I think it's really important for us to, really work with entities that represent the governments and regional authorities when we're doing perioperative global health work. Thank you.
Well, Dr. Sampson, that's very compelling, and you and your organization's ability to work in what we call a top-down approach, as well as a bottom-up approach to assess what the needs are on the ground, to be voices and invited advocates for those needs, and then to be able to reach national and supranational organizations, regional organizations, is absolutely wonderful. And we'll come back to that and ask you more about it when we have time for Q&A. So thank you, Dr. Sampson. And now I'd like to introduce you all to the wonderful Renee Stafford. So Dr. Stafford is a surgeon and epidemiologist. She has, over a decade's experience with the delivery of high quality maternal and child health services programs, especially in Africa. She's Gender Health's technical director and deputy director for the Momentum Safe Surgery program. And overall, Dr. Stafford is truly a global expert in maternal and child health education and service delivery. She's worked throughout Africa, particularly in Tanzania, and now serves on the UNC School of Medicine and Medical College of Wisconsin faculty. So we are delighted to have Dr. Stafford with us. Renee, the floor is yours.
Hey, thank you so much, Gail. I really appreciate it. And I think what's really exciting is to hear that we're going to hear common themes throughout these presentations. John mentioned engaging in the health system. Absolutely have to do that. He mentioned collaboration, both kind of top down and bottom up, as you noted, Gail. And I think that that's really important. And working across the system. And I'm going to tell you a little bit about our project and some of the work that we do. So the Momentum Safe Surgery and Family Planning and Obstetrics Project is a 6-year project that has won 6 awards in a suite called Momentum, funded by USAID. And the suite of awards is really funded to accelerate a reduction in maternal, newborn, and child morbidity and mortality. It is the only surgical award in the suite, which is really interesting and puts us in an interesting place in the suite of awards. Our core implementing partners are IntraHealth, London School of Hygiene and Tropical Medicine, and Johns Hopkins Center for Communication Programs. And then as John mentioned, we also have resource partners. So we collaborate with not only the national professional associations, with ministries of health, and we collaborate across the regions as well. So he mentioned ECOWAS. We also work with East African communities. So I think that, again, that's another theme all about collaboration and partners. The project really has the following technical focus areas: surgical obstetric care, primarily focused on cesarean delivery and peripartum hysterectomy, obstetric and iatrogenic fistula prevention, repair, and rehabilitation and reintegration, and informed voluntary choice for family planning, with focus, because this is a surgical project, on long-acting reversible contraceptives and permanent methods for family planning. So why safe surgery? Why did this project even come about? Well, it really builds on previous work funded by USAID in projects called Fistula Care and Fistula Care Plus. And a lot of research work was done in those projects, and it became very clear that as cesarean delivery rates have risen across the world, so too have iatrogenic fistula. And this provided an argument for setting up this award. And for example, in Bangladesh, the Fistula Care Plus project found that cesarean delivery rates rose from 10.5% to 39.6%. And they were seeing almost 40% of their cases of fistula were iatrogenic as a result of unsafe cesarean delivery. And they saw similar things happen in the DRC. So why is there a focus, though, on safe surgery? Well, as we heard earlier, surgery often gets siloed. It gets siloed in a vertical manner amongst facilities and amongst governments and departments, and it's not really seen as an essential part of universal healthcare. And I think that's why we're all here. That's what we're trying to advocate for. And so our project uses a horizontal safe surgery lens. We recognize that there are interdependent resources, clinical skills, and interventions that are needed to provide safe, quality surgical care. We have a global framework that uses evidence-based guidelines. We prioritize respectful care, the need for facilities to be staffed with skilled and supported teams, availability of equipment supplies, including oxygen and blood products, and of course, infection prevention control. And we really work across the surgical ecosystem. So at the community level, we're thinking about how do those people seek care? Why do they seek care? What are the barriers and the challenges to doing that? And then about reaching care. So we're working across referral systems in many of our countries. And then we work at the facility level to make sure that women are receiving high quality care. And then finally, so what you've just heard me talk about will be familiar to some of you as the 3 delay. But what we've actually added is the 4th piece, and that's linkages to care after care. What happens to women when they go home after cesarean delivery? What happens to their newborns? What kind of complications do they have? What follow-up do they get? And so these are the things that we're adding, of course, along with advocacy, guideline development, et cetera. And then we have cross-cutting strategies to really enable impact. And again, this is similar to what John talked about. We do co-creation and co-implementation at each country level to ensure that the project is country-led, country-owned, country-designed, and that interventions align with country context and with the country identified needs. This means doing large baseline assessments, key informant interviews, focus group discussions, and then bringing all of those folks together to do a workshop to design the project. And then how do we do that? Well, along with that co-creation and co-implementation, we've done some interesting things. So we use low middle income country-led human-centered design to create SBC strategies to address service demand, delivery, and uptake. So again, working across all of those levels of the healthcare system. So for instance, in India, we took an interesting approach. Rather than focusing on pregnant women, the team focused on a human-centered design process for providers to reimagine cesarean delivery experience for the women that they care for. So to put themselves in their shoes and talk about system redesign. And that's led to some interesting products and videos. We are going to be embarking in India on the human-centered design of a safe cesarean delivery checklist. That's just getting off the ground, so more to follow. We've done updated new pre and in-service curricula for priority surgical areas. So for instance, in Mozambique and Nigeria, we adapted the CUGH training manual for fistula repair. In the DRC, we're training 3rd-year nursing students to do family planning counseling and service delivery in the community. In Mozambique, Nigeria, and India, we've developed safe cesarean delivery refresher training packages in collaboration with local experts, the Ministry of Health, local professional associations, and technical working groups. Similar to what John mentioned, we did oxygen work during COVID in India, and we were able to ramp that up quickly because of those relationships that we had. And funding opportunity came available, and we were able to go with that. In Guinea, we're doing work on safe blood transfusion. In Mozambique, Nigeria, and Senegal, of course, we've developed some very specific IPC training because that was noted as needs in the baseline assessment. And then in our other curricula, IPC is always integrated into training. And globally, we actually worked with USAID on the development of a safe blood toolkit, which has been taken up and tested by WHO and hopefully will come out sometime in the next year. As we mentioned, we supported collaboration amongst technical working groups, academic medical institutions, professional associations, government and private. So in Mali, the team has developed something called the Peri-Surg Diploma, which is a 12-month diploma developed with the National Council Order of Physicians and Faculty of Medicine and the Society of Obstetricians and Gynecologists. It includes didactic simulations and internships. It is competency-based and covers cesarean delivery, peripartum hysterectomy, postpartum family planning, and permanent methods. And 47 people have already been trained in that 12-month curriculum in the first year. In India, we work not only with government facilities, but we work with the private facilities as well and associations. So we've done work closely with FOGSI, which is the Federation of Gynecologic and Obstetric Societies in India, on a safe CD guidance document for national adoption. In Rwanda, the team has developed a new curriculum in collaboration with the Ministry of Health on an induction program for new graduates from medical school. And that project in the initial stages became so successful that the Ministry of Health added nurses and nurse midwives to the mix. So we're really excited about that. In Guinea, we've collaborated with the National Center for Blood Transfusion on training, et cetera. I could go on and on. One of the other things that we really try to focus on is supporting country institutions to have and to use improved data within quality improvement frameworks. So for instance, in Nigeria, our team has worked with the Ministry of Health and the information technology folks to develop a cesarean delivery and fistula dashboard within the national DHIS2 and HMIS, which is really exciting. And that's really coming along nicely. In India, our team has worked to develop a cesarean delivery referral and cesarean delivery audit application. So the government of India has mandated cesarean delivery audits in high volume facilities, and the team has now taken that document and developed an app with it in order to get better data on cesarean. So I'll stop there because we could talk forever on this, and thanks so much. I'm looking forward to hearing the rest of our panel.
Well, thank you so much, Dr. Stafford. And you're right. We share your passion and could talk for a long time about it. And we will have an opportunity both hopefully at the end of our session and in the third hour of this webinar to, I hope, constructively exchange ideas that will help us point the way to the future. But thank you so much for sharing really important information with us to help frame the frontline healthcare workers' approach to the politics of global health. And now it's my great pleasure to introduce Keith Miles. Miles is just an absolutely wonderful person, longtime member of the G4 Alliance, who is the executive director and founder of the Safe Surgery Initiative. I think he is really onto something very, very important here. It's a nonprofit organization that he founded that provides on-site surgical device and biomedical refurbishment, as well as sterilization capacity building and education in low and middle income countries. I've seen his work firsthand. It's extraordinary the way he's able to make a difference in terms of the sustainability of the instruments that we use in the operating room and critical care. He has more than 15 years experience in the device industry, and he was really compelled and inspired to found his company when he saw the unsafe conditions of surgical tools that were being used in some parts of the planet. So I'm really just so proud and pleased to be able to bring Keith Miles and his expertise and experience to you today. So Miles, the floor is yours.
Thank you, Gail. I would like to say thank you to my fellow panelists and for the invite to be at this meeting. We work in biomedical engineering capacity building, as Gail mentioned, and from our perspective, we're kind of left out of the conversation, and it's a critical role that we play to make sure that clinicians have the tools and equipment needed to provide safe, adequate care. So we look at things from a different perspective, and we're looking at the political support for biomedical engineering capacity building. The consequences of broken or defective medical equipment include delays in treatment, long-term risks of health, higher healthcare costs, long hospital stays, and worst of all, loss of life. The proportion of this unusable equipment is even higher in countries where biomedical engineering has not been fully integrated into the healthcare sector. There are major problems of lack of appropriate human resources to design, develop, and manage medical equipment in less developed countries. The current state of disrepair. We've all seen this before. Equipment graveyards, rooms in hospitals and low resource settings going unused for various reasons. Maybe it's a plug and a component part, manuals, consumables, or untrained staff who can't use the equipment safely for patients. According to the WHO, between 50 and 80% of medical equipment is out of service. Of the hospital surveyed, 85% in Africa, 77% in Latin America, and 60% in Asia reported a shortage of skilled biomedical equipment technicians who are capable of ensuring the safety of the medical devices used to treat patients. Well, why is that? The simple answer is it's not plug and play. While multifaceted, medical technologies obtained from the developed countries cannot offer lasting solutions for low to middle income countries. The heavy reliance on products and services imported from industrialized countries is often not suited or sustainable for these environments because the equipment isn't designed for harsh environmental conditions, unreliable main power supply, limited infrastructure, and lack of support from manufacturers. Ultimately, a training model needs to be adaptable to the realities of the local environments and attentive to the issues of reproducibility, scalability, and sustainability. So how do we troubleshoot our way forward? It's difficult to talk about biomedical equipment technician training in low resource settings without considering the context in which individuals are trained. The ecosystems in which technicians are trained includes key elements of national will and commitment, social, political, and economic stability, individual leadership qualities, education, procurement policies, professional associations, and history and culture. It is therefore necessary for engineers to innovate sustainable solutions and overcome these issues of medical device adoption. BMEDs can improve healthcare systems by designing sustainable solutions that are appropriate for the developing world. Moreover, we have to establish biomedical equipment center of excellence. These programs would train the next generation of leaders and thinkers who can navigate the social, political, and structural complexities of their countries and design and develop the most appropriate medical technologies. Schematics for success. We've had great strides over the last decade in capacity building programs from various stakeholders and funders. The government of Kenya initiated a capacity building program for biomedical technicians at the Kenyatta University Teaching Hospital. 5 international companies like B. Braun donated medical equipment for the lab and provided company technical experts to train local technicians. The key component for this particular program is the use of experts to train local staff for sustainability. And that's why this program stands out to me, because if we're just donating equipment and not the technical know-how to maintain it, it becomes, like we've seen in previous slides, just another piece of equipment and another graveyard. Another great example is the Society of Critical Care and Medicine AIRS project, which is championed by our other panelist, Dr. Sampson, which will improve access to oxygen in West Africa, working with the governments, the Gambia, Liberia, and Sierra Leone. An important part of that program, and which is something that Dr. Sampson really wanted incorporated into it, was the training of local technicians to maintain that oxygen generation plants and a TOT model for sustainability, so those technicians will be able to go on training future technicians as the program developed and expanded. On a national level, working with the Federal Ministry of Health in partnership with Smile Train and Safe Surgery Initiative, we organized surgical instrument repair training for biomedical technicians across 6 geopolitical zones. The technical aspects of that program have since been fully supported by local technicians who receive additional training and have now trained technicians in every state of the country. We empowered the government of Nigeria with the technical expert, and now they're able to sustain that program and locally own it and reproduce it as they see fit. Biomed technicians save lives by maintaining medical devices. They also save money by keeping equipment functional, making the case to governments that investing in biomed training reduces expenditures over time that can be shifted to resources for other healthcare services. So how do we go from reactive to preventive? Professional development. Change starts at the hospital. We have to upskill our biomeds, giving them a seat at the table and valuing their opinion during the planning, procurement, and implementation of healthcare technologies. Advocacy. We have to champion the role of HCM workers have in building, improving, and sustaining healthcare ecosystems. These are the unsung heroes. They work in the background, keeping the OR lights on, the oxygen flowing, the patient monitor beeping. We have to advocate on their behalf because they're too busy in the workshops, calibrating, refurbishing, and running diagnostics to keep medical devices safe and functional for patient use. The stakeholders, gathering stakeholders from all sides of our healthcare system, the manufacturers, technical expertise, universities to create curriculums and training programs, governments to provide resources and support, and utilizing CSO and NGOs' years of experience on best practices working in low-resource settings. But most importantly, we have to innovate, tapping into that local workforce to drive innovation in medical device design and manufacturing that is best suited for those countries. We've seen this in other industries entering emerging markets. And we can harness that innovation. We can manufacture medical devices on a local or regional level, create efficient supply chains, have technicians who can service and maintain that equipment, and provide a higher standard of care to patients in those countries. This is how we build political will to improve healthcare technology management in low resource settings. Thank you.
Thank you very much, Miles. What you're doing is critically important, and I'm so glad to see that you're also training local people to be able to maintain that. So you really have a sustainable vision for sustainability of equipment, which is really important to everything we do. And I know that we'll have more questions for you when we can move to that part of our program. So we'll move on now to our fourth speaker of this session. It is such a pleasure to introduce my friend and colleague, Olubunmi Lawal Ayudun. Bunmi is a very valued member of the Permanent Council of the G4 Alliance. She's chairperson of our Nursing and Midwifery Working Group, one of the most active of our working groups. There are nearly 20 now within the G4 Alliance. She's an expert in health policy guidelines and advocacy, key influencer of the SOANP. I'm correcting myself because we know we need nursing in our national surgical plans, and she was involved in that in a big way in Nigeria. She's just a thought leader and a cherished thought partner. So I'm delighted to have Bunmi speak to us today. Bunmi, the floor is yours.
Thank you so much. I'm so excited to be here. Trust me, when I saw the list of the experts that will speak on this platform, oh my God, I said, can I stand these people? Jesus, I actually want to take cover, you know. But trust me, with Gil, there's no hiding place. Greeting from Nigeria, next slide, please. Yes, so I just want to quickly say a very big thank you to Madam President, who is online right now, of G4 Alliance, in person of Dr. Obembe from Nigeria. You know, we Nigerians, we are doing amazing. Trust me when I say so. And I want to say shout out to, of course, the immediate past president, Dr. Ruben, who has been a voice for nurses all over the world. Next slide, please. Yes, just to give a small brief or a scorecard about Nigeria, where we're coming from when it comes to ENSO, that is the National Surgical Obstetric Anesthesia and Nursing Plan, which is the scope I'm going to be sharing with you in the next few minutes. Nigeria, we all know, we are the giant of Africa, the largest populated country in Africa. I'm excited to say that. But come on, when it comes to surgical performances, we are not doing well because we only have, before the ENSO policy, we only were able to do 166 surgery per 100,000 people, compared to the global recommendation of at least 5,000 per 100 people. That is one area that also ensures that the government and the partners really get on board when it comes to ENSO formulation as a policy, and of course the implementation. Now also, it will also be important to mention that 65% of Nigeria are impoverished every year as a result of surgical expenditure. And this is worrisome. Again, our healthcare insurance only covers 5%. Now, can we talk about equitable surgical care when our people who need the surgical intervention cannot access it just because it's too expensive for them? Or what can we say as a stakeholder when our people need to sell their lands, need to sell their cattle just because they have a child who needs surgical intervention? Now, to talk about the severe shortage of all professional body experts is another reason why ENSO comes to play, and of course is really making impact, which I'm going to share with you in the next few minutes. But again, I also want to emphasize delay in seeking surgical care. These are all issues around having to fight so strong and ensure that ENSO comes to play in Nigeria. Next slide, please. Yes. So again, there's a problem of, I previously mentioned that there's a problem around shortage. It will interest you to look at this when you look at Nigeria map here, which means that when you come to nursing workforce, we have less than 10 nurses per 10,000 population as of 2018. Trust me, every second nurses are moving out of the country, which is another dilemma when it comes to quality surgical services. Next slide, please. Now, ENSO journey. We all realize what the Lancet Commission said in 2015, looking at specialization workforce, access to timely surgical volume, we've talked about it, perioperative mortality, which is another bottleneck right now. All of these put together, with what I've said initially, also give us that justification to say, hello, Nigeria, we are going to do it differently. Next slide, please. Now, how do we respond to this call? How do we respond to the need of the people? I want to say toilet to my government, Nigerian government, and partner stakeholders who really start together and ensure we have a robust plan when it comes to surgical plan. And the journey started on the 7th of July, 2017, and 2019, it took us 2 years. It's not a joke at all. But I just want to say thank you to Professor Amen, who really ensured that we and everybody as a team, voices were heard, synergy were harnessed and galvanized. And that is why we have a different story when it comes to ENSO Nigeria. Next slide, please. Now, just in a few more minutes, I'm going to be talking about building political priority for nursing in surgical policy. How are we faring? What impacts has ENSO having to lay emphasis on nursing and, of course, children's surgical care? What impact has it made? Anyway, I'm going to midstream it to nursing community. Next slide, please. So the uniqueness of Nigerian surgical plan, unlike every other country as we know, who have started ENSO or their surgical plan, is the spotlight on nursing and children in our own plan. And what is the return in investment for us as nurses? For the first time for me, having spent about 23 years as a nurse, there is a participation, when I say participation, full participation of nursing community in policy development. Again, that also leads to promote of ownership. Now we all own it. It's not just for designated people. No, it's all about the team. We all own the surgical plan and the care we have for our people. Capacity strengthening, that is amazing reward that nurses have enjoyed, capacity in different levels, capacity in terms of research, in terms of quality improvement care, in terms of perioperative care, a whole lot of capacity strengthening and advocacy. Trust me, most of the time you see nurses don't really speak as such. But right now, ENSO has really put that confidence and competency when it comes to advocacy. And that is why right now you see the nursing team moving to the community, identify the children, the adults who need surgical care, and refer them early. That is really important. Economic empowerment, trust me, you see some of this training has really boosted the CV of some of our colleagues and have placed them on better negotiation when it comes to rewarding of their services. Patient safety, that is really, really important. And that is why you see initially the uptake of WHO's surgical safety checklist was downplayed a little bit. But afterward, trust me, if you go to especially our tertiary facility, you see a lot of checklists, PACU checklists, the staff checklist. That has also significantly improved the care that we provide. Next slide, please. Yes, I've made mention of research, safe instruments, and I also want to say that has also given us as a profession visibility. Now, when you come to talk about surgical plan, a lot of partners, we reach out to nurses and they look at team, not just one segment, team, and team makes it better and team make it perfect. Trust me when I say so. Next slide, please. Yes, why I round up, I just want to say, looking ahead, looking at 2024, looking ahead, what is going to happen? I just want to encourage the stakeholder, you that are listening to me right now, to see that policy that prioritize safe staffing is one key area we've not been able to achieve. So when you want to nurse ratio patient is another area that we need to look into. Leadership, visibility, monitoring and evaluation of what we've done is really, really key. And I want to say at this point in time that thank you so much to G4 Alliance, thank you to CUGH, thank you to all the leaders who ensure that nurses are ahead and of course seen. Thank you and over.
Thank you so much, Bunmi. Nurses are essential, as our biomedical technicians. We're all part of this same ecosystem. Well, terrific. Really enjoyed hearing from all of you. We've got a few minutes for some questions and comments. And I thought I saw Key Park, my co-moderator's hand up. Key, did you want to say
No, I put my thumb up on Boone.
Oh, thumbs up. Oh, couldn't agree more with you about the importance of nursing. Okay. If there are any questions from the audience, we'll prioritize them. But while we're waiting for those, let me just start off the conversation. John Sampson, you talked about something that you've done successfully that many of us have not. That is, not only do you work with national government authorities, but with regional, so supranational groups. And as you know, that is a very common way of working effectively in Africa that North Americans aren't very familiar with. Can you tell us more about your successful strategies in working with regional as well as national health authorities and governments?
We're connected to an organization called the Diaspora Africa Forum, which is in Accra, Ghana. And it's a diplomatic mission that's actually non-State Department. So there's some pros and cons to that. Some of the pros are that you don't end up with, with political baggage, and yet you have a connection to government entities throughout the entire continent. So the Diaspora Africa Forum is founded by a woman from South Carolina who's been living in Africa for 20 to 30 years. And she really has developed a web of connections throughout the entire continent at the diplomatic level. And so they interact with the African Union, and they're very much in partnership with ECOWAS. And because of that, we actually had an ECOWAS. When we started off our project, we visited every country so that we could literally have a face-to-face discussion with our team, the Society of Critical Care Medicine's team, and the Ministry of Health, Minister of Health for every country that we were working with. For Ghana, we actually met with the presidential advisor, medical advisor to the president of Ghana. And it was the ECOWAS representative who coordinated that, because ECOWAS has people on the ground in every single one of the 15 African countries. So literally that person could actually have a person on the ground coordinating the meetings, making sure that they're in line, that they have the right communication, making sure that when we even come into the country, we have ECOWAS diplomatic protocols extended to our team, and they're not, that they really understand that the serious nature with which we are approaching them.
Yeah. So you've hit on some really important things, and one of them, we're all humans, right? And that human connection that you've just stressed, Dr. Sampson, is really important, even in your response to a question about a top-down approach to healthcare. And that's the value of all of these champions and experts who are speaking in this part of the session, is that every one of you has personal connections. You help deliver surgical services and education, but you also have worked with leadership. Dr. Renee Stafford, you mentioned something that is very interesting to any surgeon working in the global surgery space, and that is USAID funding. And you mentioned that, if I heard you correctly, that Momentum is the only surgical award in this USAID suite. Can you tell us more about that, and in particular, how we can move so that you aren't the only surgical award in USAID's suite of grants?
Thanks, Gail. I think, the really important, so as I mentioned, this kind of award came about because of some of the previous fistula work. And so I think as we see it right now, there are a number of things we have to do. So for our project, we have to be able to show impact to USAID so that they are willing to then fund more surgical projects. So I think that's a really key piece. And so obviously we do lots of advocacy around that. We're in constant communication, both at the USAID mission level, and have regular meetings with each of the missions in the various countries, as well as on the national level with the Washington team, both around the project, but also around some of the more cross-cutting work that we do. So gender, youth, social inclusion, gender-based violence, all of those were incorporated into our project as well. I didn't have time to talk about those, but trying to widen that scope and talk about it really as a horizontal framework. And it's challenging, though, because funding streams from USAID for this project come from two sources. They come from the maternal and child health side of funding, and they also come from the family practice, or PRH, population and reproductive health. So you can only use certain monies to do certain activities. You can't use MCH funds to do a family planning activity, and vice versa. So those two silos alone make doing this kind of work difficult. And the other thing that we're trying to do is to get USAID to think differently about their funding streams. Whether we can change that, I don't know, but we are advocating for that. And then we're also advocating, trying to get people to switch their thinking and think about surgery as being essential and being part of universal healthcare.
Well, that's music to our ears, and you've not heard the last from me or G4 Alliance about how we can work better together to get the attention and the confidence of USAID. Keith Miles, I want to turn to you. Miles, what you're doing is just essential. As I said, every single place I have gone in an LMIC, this boots on the ground awareness is always mentioned, that even when there's adequate equipment, the ability to maintain it and continue to use it and use it properly is something that gets shortchanged. how could we, all of us here who care about soda care, help you amplify your efforts?
Thanks, Gail. That's a wonderful question. And when you look at the entire scope of what it takes to maintain a hospital, when you're looking at the entire ecosystem, there's nowhere in a hospital that you go where you won't see a footprint of a biomedical engineer in maintaining all of the equipment. And so I think one of the things we could do is really elevate those biomedical technicians at their hospitals. You know, as we're planning different programs, engaging with different stakeholders, especially at the hospital level, or even further on the government level, local or state, is that we ask the question, where's the biomed? You know, if we're donated equipment, can a biomed repair this equipment? What's the supply chain issues? You know, like making sure that everything we do in regards to medical equipment, there is somebody who has a technical background that can say, hey, we need this, or this doesn't work better for our environment. We need this type of machine. So really engaging biomeds in the planning process, any type of procurement process is really going to be beneficial. But in order to do that, we have to also look at how biomeds are trained in these countries and make sure that we are engaging them and giving them the professional development to be able to speak their voice and, you know, speak truth to power a lot of times in regards to the hierarchy systems when it comes to medical practice. So, you know, as we are engaging different partners and stakeholders, I think that's the way forward. Just really making sure that, you know, when we talk about surgical care, when we talk about global health, equipment is a huge part of that. We don't just do it kind of by ourselves. And so making sure that that's always a component, making sure you have some biomedical technician, engineer, or a consulting group who can help navigate those situations, and also realizing that as much as we donate, as much as we give, as much as support we lend out, those investments get kind of multiplied by zero over time. Because if we don't have the necessary resources to maintain that equipment, are we really providing safe surgery? You know, because over time, what's going to happen if that equipment isn't functioning properly? I mean, we've all kind of heard horror stories of electrical fires in OR rooms. I've witnessed those firsthand. So we really have to make sure that we're taking into consideration the environment that the equipment is going to be in, and really looking at innovating with local engineers and local biomedical technicians on how things work better and what's the best way forward that they think that can improve their healthcare system.
Thank you, Miles. Our time is limited. I want to be sure to get one question in to Bunmi. I can tell you, you've inspired me to make sure that I always bring up safe staffing ratios in any endeavor I'm involved in. But Bunmi, in just 1 minute, can you tell us what could we all be doing to increase the visibility of leadership of nursing in what we're doing?
Thank you very much. I think that is very important. And I think the first thing to do is to recognize their efforts. And not just to recognize their effort, to document it. Most of the researches, most of the reports we are getting did not really point on the value nurses bring to the table when it comes to safe surgery. So in terms of research, in terms of policy, let's have the nurses on the table and listen to them. It's all about team, it's all about the patient. Thank you.
Great, thank you. John Sampson, I saw your head up. We're right at 9, but if you want to make a final comment, and then I'm going to turn it over to Dr. Park.
Okay, just one final comment. Yeah, we're working with Keith Miles and Safe Surgical Initiatives, and one of the things that we're very pleased about that there are several other biomedical engineering developing organizations, but his willingness to do a focus on train-to-trainer technique so that we are developing trainers for maintaining and teaching others about maintaining biomedical equipment. On a development of an online training program so that so a lot of the learning can happen before we have the hands-on session, and then the ability to develop a continuing certification program so that every year they access the online training program to make sure that their skills and their knowledge base is continued to be maintained, refreshed. These are things that are within healthcare provider learning. There's no reason why they can't be within biomedical technician provider learning. So we're very pleased with Safe Surgical Initiative's participation in those aspects.
That's great. I'm glad to hear that, and we will amplify those efforts. And now here, just a minute or two after the hour, let me turn it over to my cherished friend and highly valued thought partner, Key Park, for the next session.
Great. Thank you, Gail. And then while Razi's spotlighting our next panel, first, let me just say, the speakers are incredible. This is an example of sort of bottom up. To me, we're part of the community. Their argument is spot on. But now we're going to turn it around and then invite people who really have a high level view of global health, not necessarily global surgery experts theoretically, but really they have a high level view. And we want to hear from our panelists, are we being effective, right? And so I suggest our panelists to be honest. We're open for criticism because we want to get this right? So Razi, I don't know if you have the others spotlighting. I just want to welcome Ambassador Jimmy Coker. He's a U.S. diplomat, long history involved with PEPFAR, UNICEF. He really has a high level view of global health, and he also knows a lot about global surgery. We look forward to your comments. I see Jessami's on the panel. She is actually a surgeon by training. I looked up on your LinkedIn, Jessami. I hope that was okay. But she now works at Lancet, right? It's Lancet is really the go-to for medical publication. They've done amazing things in global health with their commissions. And so she has that high level view from a publication point of view. I see my friend Terry is on the call. She is at WHO in Geneva. She's been been a witness to the global surgery movement from the get-go. And really the surgical care is really under her unit at WHO. And we'd love to hear from Terry. And then there's Keith. Keith is our partner in this event, but he's also the executive director for the Consortium of Universities in Global Health. They hold one of the major, every year, the major global health conferences, and this is the virtual part of that. So thank you, Keith, for giving us the space. But you also have a high-level view of global health. November. And then we now have, thank you for joining Minister Wanka from Fiji. Minister Wanka is a surgeon. He's a former Minister of Health of Fiji. He was instrumental in driving the surgical care as a priority for the Western Pacific Regional Office, but not only that region, globally, a champion. And I will tell you just a quick note, Minister Wanka, that as you know, you were there when Vice President Borrero convened health ministers in Geneva a year ago. Now in PAHO, they just passed a resolution to put surgical care in the Latin Americas. So this was, and you were there in a year ago, showing how it could be done. So once again, I really want you to be as honest as you can because we want to get this right. And this is a conversation. We're not going to have presentations. And I'll start off with a very broad question. And this is not, don't think about it as surgical care, but in global health, with some broad strokes, what are some of the political priorities? What are we working with today in 2023? So, and then it could be related to surgical care, but really just to set the stage of what the political, the landscape looks like in global health. Just a couple of minutes each. We'll start with Ambassador Jimmy Coker.
Thanks very much. And thanks to Keith and CUGH who have really, I think, upped the game as far as how people in policy areas like myself relate to the academic community, the universities that are part of your consortium, but also practitioners. And we've just learned the group was described as advocates, but what an impressive group of actual people with operational engagement in the field in global surgery. And I think for every aspect of health, we have remarkable stories. And every time I listen to them, I'm inspired by people who are saving lives and improving the outcomes in public health and in individual grassroots performance. So it's a pleasure to be part of this panel. And thanks to you, Keith, for bringing us together, or Terry for keeping surgery on the WHO agenda, and all of our participants. I think that if we ever made the mistake in public affairs, and I certainly as a diplomat probably was guilty of this, of thinking, well, health is a technical area and this is a biomedical problem or it's a development problem. COVID woke us up. Health is a national security issue. It's a political issue. It's an economic issue, a sociological issue, an ethical issue. This is all about equity. It's about logistics. It's about management. And it's about our national human interests. And so we need to look at health in a much more comprehensive perspective. And we who are in diplomacy and in public policy need to say, what's our value added in this? What do we have any skills that can actually help achieve public health goals? And I think we also have probably been negligent in saying, aren't there public health equities that can help us look at achieve international relations goals? Can we better cooperate as nations by working together on health, even when sometimes maybe the diplomatic tensions or the international tensions would say that it's not everything on which we agree between nations, but sometimes cooperation in health areas is a way to enlarge those areas of cooperation and agreement and minimize areas of disagreement. And Key, you certainly, I know what you're thinking. So this kind of seminar is a great example. And I guess I just start, and I'm learning a lot from Terry in this, but start where Dr. Renee Stafford left off at the last session, which is we talk a lot now about universal health coverage, and certainly that includes surgery. It hasn't always, in terms of planning and thinking, talked about the SOTA care of surgery, obstetrics, trauma, and aesthetics. And then Terry helped me think about primary care and primary health care, whereas primary care, often given at clinics, often at the grassroots level, may not include surgery or may not include SOTA care. Certainly primary health care does include those. And if we're talking about universal health care, universal health coverage, we have to look at surgery as something to which everyone in the country should have access to quality, affordable care. And so as we look at that, and again, COVID putting a multi-sectoral approach to this, what does it mean in terms of supply chain, workforce, financing, and all of the components of health systems? How do we get surgery onto that agenda? And as we morphed our workforce into ICUs to do anesthetics and intubation, it made surgery look elective during COVID. And I think as politicians, as policymakers, one of the goals of this session should be to say, no, surgery isn't elective. Surgery is part of basic care, and that we need to be sure that our resources and the financing put surgery into the kinds of plans that countries are making, national health strategies. If there are specific surgery and strategies, as this resolution from 2015 of the World Health Assembly called for, national surgical plans, those should certainly be reinforced. And now, as we're talking about national requests for financing under the pandemic fund, under the global fund, under manpower initiatives, under maternal and child health programs, as Dr. Stafford talked about, let's be sure that we're looking at the NSOPs, at surgical care, obstetric care, trauma care, anesthesiology as part of those strategies.
Thanks. Thank you very much, Jimmy. I'm going to go to Jessamy next. Tell us what you're, if you could describe to someone who's not in global health at a dinner table, what does the political landscape for global health look like in 2023?
Thanks so much, and thank you so much for inviting me. Thanks to Keith and Key for organising this. It's lovely to be here and great to have this discussion. From my point of view, I wanted to say three things about the sort of political landscape. One is we're in a landscape with multiple funding calls and requirements. You know, there are so many different funds that are wanting money for mostly vertical projects, and that obviously puts a huge pressure and a strain on finances. And that comes in the context of the global economic crisis and the normal and instinctive move for countries to look internally, to hunker down after the pandemic, to think about their own sort of independent finances for the treasury, to think about saving money, and for also to think about a sort of move towards less regional collaboration, probably, despite the successes of regional collaborations during the COVID-19 pandemic. You know, much of the optimism that we had, I think, during the COVID-19 pandemic, that this was going to be an opportunity, a huge opportunity to transform health, to prioritize health as a foundation for governments and for societies, to put that focus on, which was so clearly demonstrated during the pandemic. I think a lot of that optimism has gone, and that with the political landscape has moved on. We're at a different time, and we're starting at a place where the pressures and the priorities for governments are pretty overwhelming. And health is falling, I think, lower and lower down on the agenda, and as is climate change, probably, although we hear a lot about it, the actual actions are slightly different. So I think those are the two first things. And then the third thing is the workforce. You know, the workforce is changing demographically. It's changing. We've got 70% of healthcare workers are now women. You know, the Women in Global Health report that came out last week on the great resignation of women. The healthcare workforce is also burnt out after COVID-19. People are reassessing and changing their focus of their work and how they work. And there hasn't really been any, because of these two principal other factors of finances and the economic crisis, there hasn't really been any sort of reward or value placed on healthcare workers, I don't think. So for me, those are the three overriding things that are going on in the political landscape of global health, and surgery sits within that. And not to be pessimistic, but it's already on a bit of a back foot, because when people hear global health, they don't think about surgery. Think about HIV, think about infectious diseases, you don't think about surgery. You don't think about the fact that, you know, a third of all non-communicable diseases, the treatment has some kind of surgical intervention. That's the reality, but that's not what people think about. And so that's the challenge that we face. I also think that that's an opportunity to be positive. I think that that's an opportunity because surgery is different. Surgery is often, unlike, you know, non-communicable diseases, it's actually, you know, restorative and sort of, you can cure something, and curative. And there's a natural tendency to, you know, hold on to that and for that to be more powerful sometimes for health ministers. I'll stop there. Those are the three things.
No, that's a very sobering and I think accurate depiction of where we are today. Thank you, Jessamine. Let me go to Terry. You know, within WHO, you've had the pandemic and still probably recovering from the pandemic. You know, we'd love to hear your perspective on, you know, where surgery had landed after pandemic. Yeah, but before that, let's just get a bigger picture on WHO's political climate. My apologies. That's our second question. Yeah.
Okay.
Sorry.
No, that's okay, Key. Happy to follow. You always have good questions. Yeah, I should have learned my lesson by now, speaking after Jemmy and Jessamine, which I've done a few times, and they tend to cover most of the important points. But I would take a step back for a second. I think there's, I do a lot, my current positioning within WHO has a lot to do with integrated channels of delivery. So trying to bring together either disease-specific agendas or subsets of disease groups or populations like children, or specific interventions, groups of interventions like surgical care. And I would say the trick is to figure out, so in the current political landscape, I take your question when I hear it to be, what are the powerful entry points right now from a political communication, strategic policy choices? And those powerful entry points, they evolve. Like every decade, there's a kind of new master narrative and a new word that means good. And everyone's advocacy is my area X is part of good. Whatever that is, whether it's primary care or PHC or UHC or, et cetera, or child health or adolescent health. So the trick is, I think, to keep track of what are these current powerful entry points that ministers and policymakers, subnational planners are focusing on, and understand when you do and don't have a very strong link for your particular area of focus. And so with surgery in particular, there is still enormous power to the very traditional global health areas, these core global health areas. The most powerful one, I think, for surgery as an entry point is maternal health and the importance of surgery in pregnancy-related emergencies. So that remains a very powerful one, has been for many years. Then there are more recent ones, and I think universal health coverage is an extraordinary powerful advocacy tool for surgical care. What we are doing, the way that's manifest at WHO in my program is we have a big online platform that is the service package delivery and implementation tool. It sounds wonky when I say it that way, but it's SPEEDY, it's SPDI, so it's SPEEDY UHC. And what it does is has a structured approach to all health areas that countries might want to include in their packages of priority services for universal health coverage. And it includes for the first time all of the surgical procedures across all of the health areas. So it makes it highly visible what was just mentioned, the contribution of surgical care, for example, to NCD management, and then also the contribution of surgical care to things that people more traditionally associate with surgery, like injury. But it takes those, it actually breaks down what we mean by surgical care into all of the services that need to be at every level of the health system to achieve this. And it includes linking those to health workers and to equipment, supplies, devices, kits. And so you move from a very high level policy framing that all of the ministers have committed to, like UHC, and you're able to see that you simply can't execute that without having the surgical services in the right place at the right time and having the human and material resources that you need to deliver them. So I do think UHC is still an incredibly powerful advocacy tool for surgical care, but it can't be limited to saying surgery is essential to UHC, because literally everyone in the world is saying my agenda X is essential to UHC. And then I think it's very important, based on what Jessamy and Jimmy also flagged, to remember that UHC, as I said, it's become the new master narrative for everything that matters, but UHC is intrinsically linked to prioritization, which is your question coming up, and we'll talk more about it, but also financing. So universal health coverage represents a policy intent to prioritize a set of services that will be covered universally for everyone. And that doesn't mean the government will necessarily deliver them or pay for them directly. Maybe they control that with regulatory mechanisms, but it means that the government has committed to protecting these services for everyone. So that has, when you engage at the level of making sure surgical services are incorporated into UHC packages, you have all these knock-on effects of ensuring that that surgical care is engaged, is incorporated into finance planning, et cetera, et cetera. So UHC is a particularly unusual entry point where you get the services into the package and then they carry into other discussions like financing discussions, et cetera, et cetera. So that's one thing. And as a side set of that, just to say that helping health systems better serve the needs of people living with NCDs, that NCD is the most common entry point these days to countries revising their package of services for UHC. So this idea of NCDs as the emerging tide of the central part of the global burden of disease is very much driving work on UHC packages. And then the last thing I'll say is that we need to take a step and recognize that a lot of the ground that had been gained on advocacy for surgical care was really knocked sideways and even backwards by COVID-19. So the other thing I would say about paradigms that are dominant right now in the landscape is we are definitely post-COVID, meaning people are not only focusing on COVID now, but we are post-COVID, meaning COVID is framing the future narrative in a way that is in some ways useful, in some ways extremely problematic. So this combination of countries want to take action to ensure universal health coverage, but also to ensure protection from health emergencies. They sometimes describe that as readiness. They sometimes describe that as preparedness. The problem with the legacy of COVID is that the idea of an infectious hazard has come to dominate our thinking about health emergencies. So it used to be very obvious to people when you talked about health emergencies that surgical care was a critical part of that. Now, it just lasted so long and it was global. People are using health emergency as a synonym for infectious health emergencies and for pandemics and for outbreaks. And that is a huge problem for surgical advocacy. So you need to put it back into the all hazard approach to health emergencies. So if you can get it to be understood, what is absolutely true, that surgical care you can't achieve universal health coverage appropriately, nor achieve readiness and preparedness for health emergencies without surgical care, then you will get people's attention. But there's a couple of barriers in the way to that advocacy, and that's what we have to solve in our formulations. And then
really
I'll stop there, Keith.
Yeah, no, that was really helpful, Terry, to understand, from the WHO standpoint, how things are shaping up. We're gonna get, after the broad strokes of sort of getting the global health political landscape, the next question will be, what are we doing right? What are we not doing right? So, but this time, these questions, the question I want to answer now, Keith, and next will be Wonka, is, what do you see from where you sit, right? What are the broad themes that are coming up politically?
Thank you, Keith. First, on behalf of all of us at CUGH, it's wonderful to see you. Just thinking of Ambassador Coker's wonderful to see Ambassador Coker here, given your long political history. But just looking at this, what a great cabinet we have here. If only, right? You'd make a great cabinet. And thank you very much, Key and Gail, for your leadership bringing this together. And of course, Radsi, for all of your work in corralling us. It's no easy task, for sure. So to your challenge, Key, and I can add on to the great points that were made before by Jessamy, Terry, and Jimmy. Few things for us to remember. All politics is local, right? They're looking at this challenge. We're going to get things done. We can't look at it through our training and our lens, because that's vastly different from those sitting at the political seat, right? It's hard for us to do because it's almost anathema to us, the way we have to think. But politicians aren't going to come to us. We've got to go to them. So we have to put ourselves in their shoes, understand their incentives and their drivers. And so therefore, we have to do one of two things. One is we align our priorities with their priorities, or we actually make what we're doing a priority. And I think that there's a lot of optimism and positivity that we can do. The first, align it with their priorities. But a few things to consider. Number one, as Jessamy said, there's a lot of priorities on your table if you're in politics. You've got to make choices. Your timeline to make those choices is short. It's the electoral cycle. The second thing is that you can only do a limited number of things within that cycle. And the third thing is really important that we tend not to consider is the fiscal space. As interest rates have gone up, that fiscal space to invest in what we know as public goods has severely contracted, really contracted. And if you want a really frightening kind of reality check, take a look at how much space you would have as a president, prime minister, or finance minister, and what you can invest in for the public goods your people are looking at in the current interest rates and what the debt servicing that is required for your countries. It's a lot of wonky things I'm talking about, but basically it is how much money do you have in your pocket as a politician, as a leader of a country, to invest in the things that people are asking for? It's tiny, which means we've got to think of how cleverly about how we can frame what we're asking to provide that value proposition to be exceptionally powerful and politically attractive. So I think, and also we're looking also in the space of the world of disinformation, which has poisoned the body politic. We have to understand that because we're going to be dealing with that, or we are certainly dealing with that. So let me just suggest a pitch for action for what we want to do. Investing in the surgical ecosystem. I'm so happy, Key, we always talk, you're always championing the surgical ecosystem. It's great to see our nursing colleagues here. And Gail, you do that through G4. It's fantastic. So here's the thing. We're not talking about surgery, we're talking about the surgical ecosystem. Creates jobs, improves the economy, saves money, can be popular with the public because at some time we all need access to surgical care, or our family members do. It saves lives and reduces disability. And I put that at the end because as hard as it is probably for us to grasp, or those who are online, is that saving lives and reducing disability is not going to be your driver sitting as the finance minister. It isn't, sad to say. But it is certainly an attractive, it's critical, right? The other way of looking at it is there's a failure to act. There's a cost to the failure to act. I think we have to add both those points together. What is your benefit for acting and what is your cost for inaction? We have to marry those two up because they're two powerful arguments. And we have to do it through stories. Data kills, right? Data does not drive politicians. It drives us, but it doesn't drive them. So we have to frame the messages, and this is messaging, we have to frame our asks differently, and it doesn't come naturally to us, right? We want to put forward this wonderful, nice big report that I have on my desk to a cabinet minister and say, please read this. No, they're not. They'll read this one page, right? This is it. This is it. The one page. Put it on the page. Tell a story. Make it local. It sounds basic, but it is important because that's what could move them, and certainly is important to moving the public. And then finally, be helpful to those politicians. Engage them at the beginning of what we want to do. If you want to have a program, engage them in building the surgical ecosystem. Make sure they're part of it, and not just health ministers. Bring in the finance ministers. Bring in the finance minister's staff, because ministers change. They don't last very long, right? Some countries, they last months, sometimes a couple of years. But that cycling does not belie the fact beneath them they have the operational core. This is the public service. So engage the people that are at the upper and mid-level public service. They have a lot of power to make sure things happen or don't happen. Engage them, make friends with them, bring them into the conversation, educate them, but not only in health. We've got to bring the finance ministers in, bring in the public works folks, right? Bring in justice ministers, because the laws have to support what we're asking for, and those laws also have to be enforced. They're critically important. So just to say that all has to be done, I think, as we start talking about an ecosystem of outcomes, of goals, but we're also talking an ecosystem of actions that also have to be operationalized. Back to you, Keith. Thank you.
Wow, that was a lot of stuff in there, Keith. Thank you. We're taking notes, Keith, just so you know. So, Minister Wanka, thank you for joining. Special thanks for joining at such a god awful hour on your side. So, thanks again. You were a Minister of Health at Fiji. You attended a number of World Health Assemblies. You work with your Minister of Finance. So, love to hear your perspective. The political landscape, global health, and surgical care. Over.
Thank you, Q, and glad to be part of this magnificent panel. And also, good morning from Fiji. I'll kind of use to the timing. My son's currently in Connecticut at the moment, so I'm used to getting calls at early in the morning in Fiji. It's been also nice to be able to sit back on the other side and watch, the political landscape now that I've, obviously resigned and joined the university. And there's a few things I see, Key, and one good thing is that I can be very frank in my current role. I kind of agree with Jessamy, is that there is I would term it a health exhaustion that's now happening around the world. What's happened is we've lost the center of gravity. During COVID, we were the center of gravity. We sort of ruled the roost, so as to speak. And we talked about how we needed to leverage as much as we can. And in small island development states and also in low middle income countries, soon as COVID finished, then all of a sudden all the other priorities came to the fore. We also needed to make sure that people that didn't have access to roads had access to roads, that water, projects that needed to be done had to be completed, that rural electrification had to be done. So all of a sudden health became a back burner very, very quickly. And what I also see, and again, I'm talking from what I'm seeing within the Pacific region, and as somebody now sitting on the sidelines and watching how things have developed, is that this is further complicated by the significant losses we've had in the workforce. So the workforce losses that has happened. So, for example, in the Pacific region, New Zealand is losing its workforce to Australia and around the world. Fiji is losing its workforce to the Pacific and to New Zealand and to Australia. So the workforce has also taken senior people who can be the next cohort of leaders within health. And also they're taking away that institutional capacity, memory, and intelligence that institutions have. How the processes within institutions. As you know, a lot of our health systems are based on for those of us in the Pacific, for example, from the colonial past, so based on the national health system from England, for example, from Britain. So we're now also losing that institutional memory. How do we, the bureaucracy within, being able to get a consumable to be bought from the supplier and come through the national logistic chain system back into the country. So we've also lost that. So, we've got this small fiscal space. There's an exhaustion mentally within the country for health. And then we've lost the next cohort of leaders who actually do the work. And that is become a worrying thing and a worrying trend. And I would suggest that it's not only to the Pacific, but also right around the world from low middle income countries. Where are they going? They're going to high income countries. They're coming to America. They're coming to Europe. They're going to Australasia. So I see that there are significant challenges for health in exactly the places that we want to push global health and global surgery. The other thing that I see key is that, we talked about how we needed to package safe and affordable surgery into universal health coverage, into social care, into all that. But that packaging can also work against us, because in that packaging, when the politicians and the policymakers unpack it, they will say, okay, universal health coverage, which includes surgical care, which is looking at, ensuring that the supply chain works. Okay, let's work on the supply chain for infectious and communicable diseases then. Let's work on the supply chain for improving cataract surgery, only cataract surgery. And so that's my worry also, is that the packaging we thought would help. I'm not really sure whether, we've done, research in that area to show that it does help. And I'm wondering whether we should become pure again in our intentions. Shall we go back and say, look, we are going to push the narrative of the Lancet Commission and the 2015. We need to strengthen surgical anesthesia and obstetrics care. Just go for that. We need to also strengthen universal health coverage because it's an SDG 3.0, but the Lancet Commission and the purity of that discussion must be strengthened. And we did that with the WHO Western Pacific. We put the framework, and I also feel what we need to do is actually get WHO to hunker down and bunker down on the countries and say, show us that you're actually going forward in terms of this area. The 2015 resolution, and also for example, in the Western Pacific, the framework that we had discussed about the 10-year framework for safe and affordable care in the Western Pacific region. Those are my thoughts, Key, on the area. Thank you.
No, and I love these countering, perspectives. This is really helpful to us. So imagine now, for the panelists here, you're at a parent-teacher conference, and the student is global surgery, and your job is to give the parents, one good thing that Johnny's doing and one good thing that Johnny can improve on. So let's start with Jessamy, and we'll go around again, same sequence.
Thank you so much. Quite a difficult question, but I'm happy to start off. So first of all, I think the good thing that everybody's doing is that we're building momentum. We have continued to build momentum. I don't think that there's been a kind of up, down process. I do think we're on a gradual curve upwards, and that's excellent. I'm not sure whether that curve could be described as an exponential curve. I think it probably couldn't. And I think that's where we would like it to go. You'd like to kind of get to the point in the curve where there's so much momentum behind it that actions immediately happen. And I suppose the question is, in terms of what could we do better, is how do we get to that point? How do we get to that point where the momentum behind the movement is such that actually it just sort of takes on a life of its own and things really start to change? And that's what I think we have to come up with as a community and as a group. One of the things, when you look at Every Woman, Every Child, when you look at all of these other campaigns that have had real movements, there's always an ambassador. There's always a global leader who can bring people together, who can go over to health ministers and explain the value in this. I don't think we have one for global surgery, and I think that would be useful. If we could get one. I'm gonna just leave it there because I feel like that's a good tangible place to stop.
Love it. Yeah. We've had discussions with Tedros, and he's agreed, at least verbally, to appoint the global ambassador for surgical.
Okay, good.
Yeah. Let's see if we can push him on that. Terry, are you able to comment, or are you there? I know you have the camera off. There you are.
Yes, totally here. Just turning it off while others are speaking. Yeah, did you want to come to me, or do you want to go to Jimmy? Are you going in the same order?
We're going to go you and then Jimmy with the last commenter on this particular question.
Okay, great. I am not multitasking, Bisola. I simply turned off the camera while I was listening. Yeah, look, I don't know. I'm not sure. I guess the kid who's sitting here and global surgery is the kid. I'm not sure what that means. So I guess if what you mean is global surgery is an advocacy agenda, that's one thing to talk about. There's a huge community. I'm an incredible believer in global surgery as an advocacy agenda. I'm an even bigger believer in local surgery as a successful delivery of services to people. So I'm not sure who the kid is that we're commenting on. But
if you're the teacher, right, and giving a report card back on the global surgery kid, what are you doing? What is
right,
it?
right. But what I'm saying is I don't know who that kid is, right? Altogether,
Yeah.
There's so many multifocal aspects. So I think what I will do is also answer Chris's question in the comment. He's asking about what WHO is doing about costing and supporting an understanding of the cost of surgery. And I think it's an incredibly important question because it relates to what others said about finance ministers and limited fiscal space. People believe instinctively that surgery is very expensive and that it's extra somehow. And it's outside traditional global health areas. And that's a problem because none of those things are true. So I think that one thing that we could do better is really communicate in the frame of exactly what was raised before, the cost of inaction, but also very related the return on investment, because the only way you're going to get the finance ministers to listen to you, they're lovely people, but in fact, they're just not oriented. The narrative is not oriented to listen when you say we can save lives. Their narrative is oriented to listen when you say return on investment. And that is a very, very easy case to make for surgery. So that's super powerful. The other thing is when you talk about intersectoral engagement, there's really a big narrative that makes that easy for surgery, which is road safety. So it's inherently cross-ministerial. Finance ministries get involved, transport ministries get involved. It's the top killer of everyone age 5 to 29. And surgery is the treatment for almost all of the most serious experiences that people have with road traffic crashes. So that is a very powerful entry point. It's, again, it's limited. It's not the whole thing, but it's, you know, it's 10% of the global burden of disease injury. And as Jessamy said, it's nice to, you know, to identify something where action can be taken. So I think the global surgery community, to the extent that it's a hegemonic creature, which I don't think it is, that's what I'm objecting to. But in any case, I think that we're underutilizing narratives about return on investment, and we're probably underutilizing road safety as an entry point in this particular moment. And then again, I would say we're really, it's both a good and bad. The kid had done a great job at linking the priorities for global surgery into the narrative preparedness and readiness. And then that was very much lost in COVID. So again, I would reiterate the need to reconnect those dots, and we're not doing that right now. We're in a kind of defensive crouch and arguing and making the neglected child argument. And that is not as powerful. Ministers don't want more problems. People are bringing, and Dr. Wanga can testify to this, if you see somebody at 10 o'clock, you've already seen 10 people who have brought you their problem. We need to do better at bringing surgery as a solution. We need to say, you've committed to these 10 goals, and here's how surgery contributes very powerfully to those goals. So it's not moving away from surgery at the center of the advocacy, but it is recognizing your audience and framing as a solution, not something neglected that needs to be taken care of. So we need to get back on the active foot about promoting surgery as a high impact, highly affordable solution.
Love it. Love surgery as a solution framing. Keith, how's my report card looking? Or how's our report card looking?
Oh, I think you guys are doing fantastic. And this is just such a wealth of information. And for all of the attendees, this is being taped and it will be shared. So certainly all of us, I think, on this call will share it through our networks at CUGH. We have 38,000 people within our network. We're definitely going to share this worldwide. So your reach is going to go far beyond the people, the wonderful people attending the session. So a couple of things just to add on. I think it's important for us just to reiterate our message. We have a surgical ecosystem. And I think we also have to bring in the private sector. And interestingly, when I was in Parliament, when I was meetings of chief executives, I asked them, so what was your major concern with regard to your firms? And they said the health of their people. That was the health of their people, because it affects their productivity, right? So what we have an opportunity to do is to bring in key players in the private sector, particularly those, depending on what country you're in and how much money influences the political environment. Find out those people who are actually backing the people in power. Find out what firms those are. Who are those leaders? Ask them what their concerns are, because I think we will find that the surgical ecosystem speaks to the bottom line of their companies. Then you need to bring them in as partners. You need to build relationships with them, and then use them to go to the politicians to spread our word, because they're the ones who have a lot of power. More power than a lot of cabinet members, more power than the Minister of Health. Second, just to emphasize the importance for us to go to the finance ministers, although, as Terry said so well, they're not knowledgeable about the blood and guts, the epidemiology of what we're talking about, but they know the bottom line. And so the surgical ecosystem is a really important bottom line advantage to finance ministers, who have a lot more power at the cabinet table than any Minister of Health has. Second, find out who the power brokers are in the president's or prime minister's office. They're important because they speak to the leader, and those leaders listen to them. They may be somebody they're 20 years old with short pants, but they will listen to those people. They have a lot of power. Find out who they are and engage with them. And finally, on the prevention issue, which is an incredible value proposition that Terry mentioned. She mentioned road traffic accidents, but I think we miss a major opportunity key that you said, so what can we do better? Here's some low-hanging fruit, right? We know NCDs are responsible for 70% of mortality worldwide, right? The leading cause of disability. We are missing a massive opportunity to be a political force to reduce the burden of those diseases. which goes to speak to the finance minister, the minister of health, and all the way down the line. And I think what I would suggest is we need to define really some public health initiatives that will reduce the burden of those diseases. And Terry spoke about road traffic accidents, right? That's one huge thing we can do. And there's known public interventions that can be done, policies that can be done, from reducing, putting sidewalks in, reducing the speed limits, safety belts. There's a lot of stuff, right? That's simple stuff that doesn't cost money, but those are policies. Identify them and do them. And not only for trauma, but let's look at cancer. Let's look at peripheral vascular disease from diabetes. Let's look at being advocates for those who are trying to advocate for access to meds for hypertension. Hypertension, right? Wow. Countries of India, I think, has 5% of people with hypertension are actually clinically treated properly. 5% of those who are hypertensive. And we can go down the list in this group ad nauseum, but you get the picture. Let's define what those asks are. Let's repeat it. Let's tell stories around it. Let's get it into the media. Don't neglect the media. Engage the public, engage the politicians. They'll go, oh, that's simple. I could save money. I could look good. I could look politically attractive. I could get reelected. Let's use those stories. Let's use those asks. We know what those are. Frame them properly, message them properly, share them well. Thanks, Keith.
Love it. Okay, Minister Wonka, what are we doing well? One thing, and what do we need to do better? One thing.
Yeah, thank you, Key. Our child was doing well. Was scoring B plus. At the moment, it's gone down to C plus. What's happened is obviously, what we discussed. Obviously the post-COVID, the post-COVID priorities. That have overtaken health, and we are there. We are there. We talked about this, Key, several times. We are there, and we feel like we just need a push somehow to be able to continue that momentum. And that push has to be obviously in several areas. It's been discussed about the political will. The political will is so important because the political will within cabinet, within the ruling party, determines what the policies would be within the term of that government. So, obviously the political will, and how do we ensure that we continue to engage? And in Fiji, we continue to engage, and as a group of surgeons, we continue to engage with the politicians in that regard. And then obviously also, the funders. And the funders also have changed somewhat. So, during COVID and just before COVID and during COVID, we were able to insert surgery, anesthesia, and obstetrics in some of the support that we got, making sure that we had sterility within the hospitals and strengthening the processes of sterility, which included theater, making sure that we have access to perioperative, peri-anesthetic equipment that was useful for surgical care and obstetrics care. But we also now, that funding space is also dropped off because the funders have now gone back to, to disaster preparedness. So we're trying to actually ensure that in that disaster preparedness, we include surgery within the mix. And so, disaster preparedness and the other areas in which they want to fund, which obviously, as we look at it in retrospect, the areas that they identified pre-COVID, and then COVID, obviously, just like any other budgets within governments, they were taken away to be able to support the COVID response and the technical system strengthening within the health systems to be able to respond to COVID. But now they've gone back to, okay, before COVID, we wanted to fund this particular space. Now after COVID, we're going back to that particular space. And the other thing that I've seen is the funders are not short-term funders. So they fund for 5-10 years. And if you're taking loan from the World Bank to, for example, to support a particular cause in the health system, which in our setting is strengthening the hospital, it is a 20 year. So it is a long-term funding. So you can be distracted a little bit to do particular things, but their focus goes back into what is it that they decided to fund pre-COVID. And I think that's where we need to insert ourselves. We need to insert ourselves so that we have sustainable funding for the long term, because we cannot survive on short funding. And I agree with the sentiments raised that the finances play an important role. And when we talk about funding, again, I continue to advocate for support to health systems from outside financing, because again, the government fiscal space is small and it's grown smaller. And I agree with the sentiments raised about interest rates. The other things have actually challenged small and low middle income countries. The logistics supply chain has become harder. I was talking to one of the people that run our logistics chain, and he was saying, look, it's changed dramatically. You know how we can actually buy a drug and secure that particular price for 3 years. We can't do that anymore now. It's every year now. They keep on changing the price every year. So every year we have to, for example, increase by 5% or 10% the cost of a particular medicine. And what also is challenging that space is obviously, the rising costs to simple things like fuel. And when we've got low middle income countries, for example, like, Somaliland development states, Fiji has 300 islands, 100 of them are inhabited. We need to be able to take medicines and take equipment to these places. So again, the supply of, the cost of fuel. So if the budget segment for fuel is, say, 100, and now the cost of fuel has gone up, that remains 100. So if your reach was actually the 100 islands, you probably now the reach is probably smaller, or the volume they'll be able to take is actually smaller. Thank you.
Thank you. Ambassador Coker?
Yeah, a lot has been said, and I agree with the brilliant insights we've had. But the one thing I haven't heard enough, which to me has really been a remarkable phenomenon, has been the capacity that's been built in low and middle income countries just in the last generation. That at the turn of this century, it still was a model that, for instance, many of the G4 Alliance organizations were sending surgeons from the United States and other developed countries to perform surgeries in low and middle income countries. Those organizations now have repurposed, and they are taking advantage of building surgical systems in those countries using local talent and looking at new ways to deliver that surgery much more sustainably in those countries. And programs like yours, Key, and the Global Surgery and Social Change are looking at how do we embed those systems, not just to deliver services, but to look at social change. In what context do those systems operating? How do they become much more resilient? So the good news is the student is that we have that capacity. And I can't help but mention, I see Nelson Siwankambo is on this call. When I arrived in Uganda 25 years ago, I didn't know, and I bet there are a lot of people who didn't know. Nelson Siwankambo, who became dean of the medical school, Makerere Medical School at Malago in Uganda, is the person who identified SLIM as HIV. He is, among researchers, among academics, is to the HIV world the prize winner. He got the key. He has the golden award for doing something that all the rest of us in the world who've worked subsequently on HIV stand on his shoulders in trying to make these programs nationwide and to use the science to actually benefit people. And there are people like Nelson in every country now, but I don't think we as a global community are fully taking advantage of how good these people are and how many of them there are. And so Nelson is of my generation. We're older now, but there are just dozens, there are hundreds of people who are like that, who are now in the ability to really change the way we talk about surgery, about medicine, about healthcare. And I think the failing grade we're getting is that we're not communicating, you're not communicating to diplomats and policymakers like me about that, but I don't think you're communicating within your own health systems. It seems to me the point Keith was making, we're not referring people for care that's available within their own communities. We're not referring children with cancer symptoms early enough to get them diagnosed maybe before they need surgery, or for when the surgery could be simple with high chances of survival. We're not referring people with other conditions where the prevention part or the early engagement or treatment could actually prevent surgery, or where the surgery has a much higher chance of success or life-saving consequences. And the same, I'm glad people mentioned road safety, because there are actions that governments could be taking based on science. The auto safety requirements to sell a car in the United States are very high. You need to have lots and lots of safety features for that car. The same features are not required in Kenya or in Nigeria. Just the idea of what are required for a car to be on the road in many countries would help, as well as the other things we talked about in terms of safety of lanes and sidewalks and lighting and so on, things that the public sector could do at relatively minimal cost, because some of them are burdens actually on the manufacturers or the dealers of cars, not on the public sector itself. So it does seem to me that in communicating both within our systems, how do we look at referral? How do we look at making a health system cohesive? And what Dr. Waka said at the very beginning of the discussion, that the inherited surgical systems, which really don't apply to the kind of workforce that now is in many low and middle income countries, I think needs to be approved with task shifting, with empowering. And I saw some of the chat about empowering, for instance, nurse anesthetists in circumstances where that makes a lot of sense. We really need to look at how the regulations could democratize care, could empower people at lower levels to provide care, because that is in many communities, and to be sure that also the community health workers and people in primary care facilities are able to refer for more advanced care early enough to make that care most effective. Thanks.
Thank you. And so we have about 3 minutes. We'll go to an open Q&A. I hope the panelists, I know you're all busy. If you have to leave, we understand, but if you can stay, we'd love to open this discussion more widely. But before we do that, I just want each of our panelists to give maybe 1 or 2 people, or names, if you can name names, who we are not engaging and we should be engaging. And so be specific as possible. It's real practical for us because we're going to follow up on it. So we'll start with Terry.
Okay, that's not fair with no time to think about it, but let's see. I guess I hate to use something that's already been discussed because it's said often and it's very hard to do. But right now, your ministers of finance, it's probably the biggest barrier. I think that's one thing. And then it's not a specific target, but it's a specific narrative. Everyone is focused on cost right now. And you need to prove this will save money, not cost money. So your target for that is everyone. So I would say your minister of finance is the person maybe that you're not talking to as much, but it is your health economists in terms of the mechanistic way that you get your message to the ministers of finance. So the ministers of finance at the high level, the health economist as the road to the finance minister.
Perfect. Keith?
A few things. So one is I would look at, again, also the senior public servants in the ministries of finance, as Terry were mentioning, is really important. I'd look at senior members, I'd look at senior individuals of private capital because they have a lot of money. So there's nothing precludes one from going to the head of BlackRock Capital and say, hey, this is interesting, come to the table, right? Speaks to your workforce. So I would do both of those. And then, as I said, we really have to engage the public health champions to be able to bring them on board, because no one can speak more eloquently to public health challenges, I believe, than those who have to deal with the consequences of trauma, maternal crises, NCDs from a surgical perspective. Our efforts upstream can do so much to prevent suffering downstream. So let's bring them to the table. Thanks, Keith.
Keith, I see a Zoom call coming with BlackRock Capital with you.
Awesome.
Great. Minister Wanka?
Yeah, thank you, Terry. You said exactly what I was thinking, but I wanted to take it to another level. In low middle income countries, we are very regionalized. So, for example, we have Pacific Island Forum that looks after the Pacific. I know for sure that you have other organizations, for example, in Latin America, for example, specific, and again within Africa. And usually, what happens is these organizations have a secretary general. This secretary general actually communicates with the head of governments and look at particular themes and topics that they discuss on a yearly basis and plan for long-term 5-year, 10-year periods. And a lot of funders like to fund directly into regional programs rather than specific to one country. And so I'd like us, to be talked to regional secretary generals. For example, the Secretary General of the Pacific Island Forum, for example, because these are the ones, they're usually very senior stateswomen or statesmen, and they're the ones that drive the regional agenda, for example. And a lot of the funders, like as I said, are now wanting to put money more into regional capacity building and regional programs rather than specific country-wise. So maybe we should involve them.
Thank you. Ambassador Coker?
Yeah, we're engaging that we're not engaging. It was disappointing to me that how few heads of state and government actually attended the special sessions at the UN General Assembly. So in some ways on health, we're actually not reaching high enough in my view. So at one level, yes, I think we really need to make this an issue that looks like it's of national security and national kind of importance. At the other level, I've been so impressed too by the people you're working with in your program, but all across the world, of how medical students and university students all together, Keith must deal with these people every day, how engaged they are in policy. They want to be part of this process. And so many of them are very creative, have technical skills, are looking at virtual solutions of hackathons and so on to try to solve practical problems. And I think that we as a community of sort of policymakers and implementers probably haven't tapped that resource well enough either.
Thank you. And then Jessamy, who should we be contacting?
I am not sure I've got anything to add to what people have said, but I would say educators in universities, senior public health professionals, I'm thinking about the chief medical officers, really, the Chris Whitties of different countries who are sitting down with governments all the time and can continue to make that case and put that pressure on, and then funders. And I think that's
Great.
it.
Thank you so much. And I know I didn't stay strictly to the script. I apologize. Now, if you can,
that's always the best ones.
Yeah, and we're going to enlarge the spotlights to the panelists from the first session, and then Gail and I will co-moderate the Q&A and start engaging our audience. This is a Zoom call, so it's not a webinar. We really wanted to have it interactive. So Gail, are you there? Oh, there you are. Great.
I am here. Well, this has been really interesting and really informative. I do want to give an opportunity to anyone in the chat, but waiting for that, I loved what Keith Martin said about, echoed by many of our expert panelists, on making the case for creating jobs. And so I wonder if we could elaborate upon that. We've engaged, Terry, as you know, with Jim Campbell, who does healthcare workforce at WHO, had a side event at the most recent WHA that was very useful for many of us. But what could we be doing for and with the healthcare workforce that would both solve our community's personnel problems and delivering care, but could also solve the Minister of Finance and even the President or head of state with problems with not enough jobs? That's open to anybody. Keith and Terry, you inspired me to ask the question, but I think all of our panelists have valuable things to say about that. Here's an example. While you're thinking, I heard on NPR today interviews with teenagers in Gaza about what they want to be in the future. And the three said it didn't matter what they wanted to be. They thought they would either be a martyr, a victim, and the victim would either be a dead or disabled person or a terrorist. Now, that's not true of every country in the world, but wherever you have young people who don't have work, we're going to have problems, right? We're going to have problems with violence. And so it seems to me we have people who need work and we have a surgical ecosystem that needs healthcare workers. How do we marry those two facts?
Great. I see Adira has her hand up. Then we'll go to Bisola, then Terry. Is that okay? Yeah.
Thanks, Keith. Can you guys hear me?
Yes.
Yeah.
So I had a couple questions that I put in the chat. I think these are great topics. But I think the first thing, to the ambassador's point, there are so many things that are going on that we don't know about. So trying to really focus in on whatever areas that everyone is working, and trying to build a map of all of the stakeholders and all of the people that are on the ground doing things and trying to connect them, I think is very helpful. Should be easier to do in these times. But the other thing, I think, to the point of the automobiles, in a systems dynamics approach, and we're working on a systems dynamics model for global surgery. If you look at trying to increase safety standards, it'll be hard to get the manufacturers to do that. But if you can, at least in a limited way, or change some things, speed limits, et cetera, you'll actually decrease the number of vehicles on the road, right? Because you're going to increase the price point for the vehicles. And then the last thing, I think, I don't know how much progress we've made on this, but I just finished business school and sat in with so many young people that are involved in entrepreneurship. There are venture capitalists out of Nigeria and there are venture capitalists out of Botswana. They all want to get into fintech. Why can't we get them into health tech? And why can't we get them investing in their own communities? And I think that goes also speaks to collaboration. So I don't know if any of you have any comments on that, though they're kind of my open-ended, more questions for another symposium, maybe.
So does anyone, Terry, did you have an answer for a question that was asked, or do you have a question?
No, it was just to give a quick answer to Gail's question.
Oh, okay. Then let's see this. Terry, you answer Gail's question, and then the panelists can think about Dira's question, and then we'll go to your question, Bisola. Okay, so Terry, go ahead.
Great. Yeah, it was just a quick one. When you're trying to link strengthening surgical services to these kinds of economic opportunities for communities, so creating jobs, but also beyond that, usually you need to formulate that in a different way, which is through hospitals. So hospitals are seen as capital investments. Hospitals are seen as meeting community needs, but also being consumers of community businesses, et cetera, et cetera. And so it's hard for people to understand the idea that you might just somehow sort of drop surgical care in and then see that as an employer of the community, whereas there's quite a well-established narrative of looking at hospitals that way. So it's one of these things where you slightly tweak it. It's not about decentering from the surgical care agenda, but it's about framing it in a way that will make a lot of sense to the World Bank, to community activists, et cetera, et cetera. So that's an important pivot if you're trying to frame surgical care strengthening as if you're trying to make the employment argument, the job creation argument.
So can we move on to Dira's question, unless someone has a comment to Gail and Terry's train of thought? Okay,
I have a comment.
Yes, go ahead, Bisola.
Yes, first I want to talk about creating jobs. Now, we train people, but in low and middle income countries, we expect that they work for free. And so these people get discouraged. We have porters, we have all sorts of people, but are they being valued and are they being paid? That is a situation, and that makes them want to go into other things. And sometimes they take a second or third job, or the trade, even within their jobs, because they are not being valued and they are not being paid. So there are all these people there who have been trained, but are not well remunerated. So that's one. Concerning reducing cost, really, when we work with project managers who know about lean management, Sigma, and all those things, it's not about if we don't provide quality and safety, then the cost will, the cost will be reduced or something like that. It doesn't work that way. I'll give you an example. Many years ago, we ordered laryngoscopes as part of a new hospital equipment project. And I'm talking about my hospital, University of Port Harcourt Teaching Hospital in Nigeria. We ordered laryngoscopes, but because the order was made by a surgeon, he wanted size 2, 3, 4, 5. And in the pack, it's actually size 1 to 5. So what the supplier did was he removed size 1 for neonates, because the order was 2, 3, 4, 5. So sometimes ignorance of not knowing what to order and the quality of things will make the supplier take advantage of this. It's the same box, it's the same case. So it's good to get people to work together and understand that you don't remove maybe the spare tire from a car, which is quality, which is safety, because you don't know, and you tell the manufacturers, I just want a car with 4 wheels, and that is perfect. But in the standardized world, the supplier and the manufacturer knows that a car must always come with a 5th or the extra tire for safety. So we take advantage of the ignorance in low and middle income countries and just give them what they want or what they request for, because they don't know, and we have not passed this through the quality and safety process. So that's just what I want to say. Necessarily, it doesn't mean that training someone very well, a workforce training, giving that person a good training and good exposure for 3 years or 4 years, in the long run, does not mean that it is more expensive than just calling porters, hey guys, come here, give you 1 week training on how to inject ketamine, and that makes you an anesthesia provider. No, it doesn't help us. Thank you.
Thank you, Bisola. I hear you loud and clearly. You and Bumi, when you speak, I listen. But your point about workforce and valuing them, I think I want to be able to, I think I can tie that to what Dira was talking about. Dira is an orthopedic surgeon. She's worked overseas for years and then switched to getting an MBA at MIT Sloan. And so she now has sort of this perspective that's just more beyond the technical aspect of surgical care. And she talked about entrepreneurship, right? Innovation, health tech, fintech. What we're talking about is healthcare workers are not being valued. It's because there's no system for healthcare delivery to thrive economically. And so how do we bring entrepreneurship, private sector, as Keith has discussed, and delivery of equitable surgical care? I think that they're all interrelated in one way or another. So I just wanted to just bring that together. Well, let's just go in sequence. Minister Wonka.
Yeah, thanks, Key. I was just, while answering the initial question posed, I hope also I can also in some ways answer the question that you brought to the fore. One of the things that, when we talk about safe and affordable surgery, which are 3 main things: a laparotomy, an open fraction, a cesarean section. The other thing that we did in Fiji was said, look, we need to turn people around so that they can go back to work very quickly. So what we need to do is have a mechanism where we can do hernias very quickly, do the tubal ligations, because, that's important. And so we identified a package of important things that people who work, for example, our economic sector is based on the tourism industry. How do we ensure that the tourism industry, if they have any problem, they can come, get it done, and go back and work and support the economy. It is important for not only supporting the economy in general, but supporting their livelihoods. The other thing is, apart from the tourism industries, there's 15 employment areas that support the tourism industry, 15 to 20. So people who work at the airport, people who fly planes, the hotel, the administrators in the hotel, the people who cook, the farmers that support them. So how do we ensure that the farmer, when he has a hernia, who's supporting the tourism industry, gets it done, goes back to farming? Okay, then what do we do? Make sure that everyone has a mesh. Okay, make sure that people that are working, when they come, we can do a lab calling, get them back home again. So I think that's also useful in terms of low middle income countries, in identifying also a package that you can sell as to the finance ministers and say, if we support surgical care, we can turn workers around very quickly that can go back and contribute to the economy. They won't be another addition to your social protection package, but they will be an active member of society. Thank you.
That's very helpful. Thank you so much, Mr. Minister. Bunmi, your hand was up. You have a
Yes, I just want to quickly comment on your question. And that's just speak to my mind. Who are we really engaging? What happened to the Ministry of Labor and Employment? Do we talk to them? Do we speak to them? So we've left them so long that they don't even understand our need. So what is the policy within the labor market space? Because there's no point training 10,000 of people, and at the end of the day, the government just employ few or no employment at all. So I think we need to speak to the right people, labor, their policy, and the plan they have for the country. And again, government forum in each of the states. I don't know what happened in other states. We have the governors forum. They have the statutory responsibility to employ. And some of them just place embargo when they know that there is a need. So how much are we really engaging them? So I think we also need to engage the government and the governors forum, because they need to employ. And again, we need to stop quackery. There's a lot of quackery. It's not as if people who are qualified are not there. They are there. Again, we need to work as a team. Thank you. Job placement and so many more we can do.
No, you bring up a very good point, which comes up over and over in Africa, which is people are trained, but then there's not jobs for them to go to. So let's drill down a little bit more on this workforce issue. And both Terry and Keith Martin, I'm going to ask you to say a little bit more about this. We've talked about ministers of health. Terry has highlighted the importance of talking with ministers of finance. What about ministers of labor? How do we use them to weave together the world's need for more frontline healthcare workers, most of the world's need for more full and robust employment, with what we're talking about here? How do we leverage ministries of labor? Keith, I'll ask you first, and then maybe Terry could comment upon that.
No, thanks, Gail. So not to skirt the question, but I would go back to who has the power at the cabinet table. It's the finance ministers. So the Minister of Labor is not going to come up and he's going to say, well, I'm going to do the following. There are layers above the cabinet table that have to approve of that first. So I think it's good to engage them. You're absolutely right. But the area where we can have the greatest impact, where we can push the button, is at the finance minister, but also within the president or prime minister's office. It's really important to go there. And again, let's also make sure we're actually talking about the civil service. There's a gap though that we've been working on at CUGH. And I want to just do a little pitch. We created a capacity building site, a platform that anybody can use. It's called CUGHcapacitybuilding.org. I put it into the chat. Please use it, because it's designed as an open access platform we created with the National Institutes of Health for institutions that have training needs. They can pitch those needs, and then others who have training capacity can actually engage those. It's basically like eHarmony without the romance, if I can say that analogy. So but it brings people together. That's the aspiration. So the other gap that we've noticed, because in our work in a number of countries, at the civil service area, there are huge operational gaps. So you're the minister of, let me give an example. In Sierra Leone, we're working with partners to mental health training. There are 2 psychiatrists in the country, no nurses with mental health designated training. 250,000 died in the conflict, 11,000 died in Ebola, massive need, right? They have a nice new place to train people. But of those 2 but if you ask the question, how many people in the Ministry of Health are actually designated to improve mental health care? 1. So the country's set up for failure. Can't happen. So one really important place, which we, from a development perspective, I think we have neglected for far too long, we need to ask countries, what do you need at your public service level to operationalize the public goods that you want in terms of your priorities? And this has to align with those countries' needs and priorities. So in terms of, to answer your question, Gail, I think going a little bit upstream again, we've got to ask countries, what do they need in terms of strengthening their public service? Because it is a massive gap that is chronically neglected. I know Dr. Siwan Kambo has eloquently said this, Dr. Omaswa and others from Sub-Saharan Africa. Let's listen, engage, and deal with that challenge, because nothing's going to happen unless that gap is dealt with. Thanks, Gail.
Yeah, thank you. Terry, did you want to comment again or expand upon this issue of labor workforce that is needed, and violence prevention and better healthcare as a result of that investment and strengthening the economy?
So I will start with the first one. That's a lot of topics in one. So first of all, I'd like to give kudos to Keith for somehow managing to introduce eHarmony into the conversation, because that's outstanding. But look, there's a couple of things I would say. Should you be targeting the Minister of Labor specifically? Yes, maybe it depends on the context. And I think one thing, while we're listing ministers, I wouldn't, in many cases, the health workforce is actually the health workforce for care delivery is completely run through the Ministry of Education. And so when you're trying to influence the pipeline, and when you're looking, especially as was raised, at a broad range of providers in interprofessional education, those things are often running through the Ministry of Education. So sure, it's good to talk to as many people in power as you can. I do think that we have somehow pivoted a little bit in the conversation to sort of listing hyper powerful people that most people with a government textbook could do, and that we also need to remember the particular power of where we're sitting and the actors that are in the room. So I do think CUGH, for example, has an extraordinary opportunity to work from the university as and specifically not only the roles that universities have in high income countries, which honestly is much less interesting than the role that universities have in low and middle income countries. I say this because I was just talking to a colleague today from our Western Pacific regional office, and he had done this incredible analysis in a country office where he used to work of the package of priority services for universal health coverage had been defined. They did a rapid analysis of saying, okay, here's the services you want delivered at this platform. They compared it to the health workers at that platform and their scope of practice. So I am coming back to the health workers. It turned out that only 20% of the services they wanted delivered at that platform were in the scope of practice of the health workers assigned to that platform. Within a year, they were rapidly able to pivot and expand that scope of practice, that legally protected scope of practice. So one of the most important things I think we can do is we talk about mapping, investing in health workers. We do need to consider, are the services that we would like to be delivered here, do they match the regulatory scope of practice for those providers? That's one thing. The other thing, and that is something where CUGH and educational institutions have a particular form of power, especially linked to councils, to professional councils, Then the second thing they did is they looked at the competencies in which those providers had been trained to see if they matched either the services in the UHC package or the defined scope of practice from a regulatory way. And that is exactly the sweet spot of CUGH and its power. And that also was skewed. And that also was rapidly remedied. So many countries have an incredible amount of capacity that they're not deploying as effectively as they could be. There's certainly a lot of capacity gaps, a lot of help that's needed, a lot of resources that are needed, et cetera, et cetera. There is also a lot of underutilization of what is available in many of these countries, including the low-income countries. So this very simple mapping in a country of what services do you want where, and for this group that focuses surgical services, how does that targeted set of services relate to the regulatory protections available to the providers at that level of care? And how does that relate to their educational competencies? And it was an incredibly powerful story. And literally within 1 year, they had managed to change the scope of practice and redesign the curricula in order to provide those competencies that were needed just by making it visible. And that seems to me, it's one of the most powerful stories of political change I've heard in a long, long time. And it seems to me like CUGH's sweet spot. And I recognize not everyone on the call is a university, but really universities have a much more powerful role outside of high income countries to influence politics directly. They have a very different relationship to ministries than they do in high income countries. And Dr. Wonga can speak to this much better than I can, having just moved from one to the other, I'm sure. Over.
Okay, I know, Serena, you have your hand up. You're next, but I want to give just a minute to Jimmy because he has to leave. And so I wanted to say,
yeah. I'm sorry that I have to jump off at 11:30 Washington time for a good cause. I'm flying to South Africa because I'm going to chair a health panel, which we've been able, as the new Bureau of Global Health Security and Diplomacy at the Department of State, to get onto the Forum for AGOA, the Africa Growth and Opportunity Act, which will engage the private sector. And I think seeing these priorities come together in that forum is something that we need to work more for. And I hope I can get some of the points that I've learned today onto that panel as well. This has been a terrific opportunity, wonderful work, happy to keep advancing it. And it's really terrific to see the communities from civil society, from academia, from the practitioners of surgery, from the policy world, and from the multilateral organizations come together, public and private sector, and from the various aspects when we talk about non-state actors or non-governmental organizations. It's such a diverse universe, and to hear the perspectives that we've had here has really enriched the conversation, and the surgery team does have momentum, but we also have just enormous challenges, and finances certainly looming out there, but maintaining our own momentum is going to be a challenge over the next couple of years. And I'm just so pleased we had this forum and the opportunity to bring our community together. Thanks to all the organizers. And I'm sorry I won't be able to hear Serena's interventions. But thanks.
We love having you on our
Thanks very much,
and safe
Jimmy.
travels.
Yeah, thank you.
Safe travels.
Terry, I think, has to also leave. Terry, do you want to just, before you go, say a few words? And thank you for your patience, Serena.
And I think Jessamy needs to do the same.
Yeah, just thank you guys very much for the chance to join you. And it's just a great continuation of conversations we've been having over the years, and that I very much hope we'll keep talking. So I refuse to make any final comments because I think we're very much in the middle of a conversation. So I'm just looking forward to continuing it. Thanks a lot for the invitation.
Thank
well
you, Terry.
said, Terry. Thank you.
Jessamy, before you go, do you want to say?
Yeah, thanks so much for the invitation. This is a fascinating discussion. I really enjoyed it. I look forward to connecting with you all more over the next months and years. And, this is a topic that the Lancet is fully committed to and supportive of. So if there are ways that we can collaborate, please reach out and be in touch. And I'd love to join more conversations. I'll see you all in the future.
Thank you.
Thank you so much.
Serena, thank you for your patience.
Sure, no worries. I was really late too. I've been doing a bunch of other stuff. I want to say that I'm loving the conversation. I want to applaud Gail. You asked a really tough question, and I think it caught people to the point where they were breathless in terms of their ability to react, but it's a necessary comment. I also want to point out something. I don't know if she's still here, but there's a person named Renee Stafford. I saw her comment about the importance of more deep diving kind of research. And as somebody who's a medical ethnographer and has spent years doing that kind of work, I think it would be doing a disservice to the kinds of commitments we see from our partner countries. Like we're here, we have a member of the government of Fiji. We've had Ambassador Kolker. We have allies, and I think where we can be stronger is spending time to Bisola's comment, spending time trying to learn what's happening on the ground. And it's frankly a democratic thing to do. And if we're talking about public healthcare systems, then the democracy has to be in the center of how we respond. And the responses that take place at government level, whether they're finance responses, environmental responses, international aid responses, if they're democratic, they're responding to the people and the patient populations. And so I think social scientists play an important role in terms of bridging what the people and the patients are experiencing and needing, and what those public servants want to provide, and the needs they need to make to international bodies. And so I think, just as a call that I want to make here, is what kind of resources could be put from the global surgery community, from organizations like CUGH or CUGH, and even governments themselves that want more global surgery resources. What kinds of practical commitments can be made to put money aside for this kind of in-depth research that plays this role? Thanks.
Very good
Pass back to
question,
you,
Serena. And we do, as you know, Dr. Stafford was a speaker in the first hour. So Dr. Stafford.
Gail, Minister Wonka has to leave. I just want to
Oh,
make
I'm
sure
so sorry.
I didn't,
Okay.
yeah, my apologies.
Forgive me, and then we'll go to Dr. Stafford. Please go ahead.
Go ahead, Wonka, and then, yeah, I know it's got awful early there now.
Thank you, Keith. Thank you, Gail, and thank you, everyone. I thoroughly enjoyed this discussion. And I suggest that we continue to have these conversations. One of the beauty of CUGH is that we can talk freely and push a thesis, and that thesis is something that is honest and transparent and searching, and keep governments and also ministries of health true to the Lancet Commission and the resolutions of WHA. Thank you.
Thank you for your time.
Thank you. And wisdom. Great to be with you.
Yes.
Go get some sleep. And Dr. Stafford, next, if you would like to respond to Dr. Cruz's comment question.
Sure. Yeah, actually, Gail, the comment that I put in the chat was in response to Keith's comment about we also need to document the cost of not doing something. And so, for instance, I lived and worked in Tanzania for 10 years. And what you would often see, particularly in rural areas, and it was a place where the tribe in that part of the country had a fertility rate of about 7.7, and very rural. And so what would often happen is a mother would die during pregnancy for whatever reason, postpartum hemorrhage, a cesarean delivery gone bad, obstructed labor, what have you. And you now have a family that's lost the caregiver, that's lost the one who takes care of the house, who often also works outside of the house. And those children often end up homeless. The spouse may remarry or find another partner, but they may not want to take care of those children. Children end up homeless on the streets. And so what I said was we need those ethnographic observations. We need the voice of the community to tell us what some of that cost of not doing something is. So I think it's really important to include that. And we just completed a mixed methods study around counseling, informed consent, and debriefing for women who had cesarean delivery in DRC, Nigeria, and India. We don't have the manuscripts ready yet, but part of the mixed methods approach was doing those ethnographic observations. focus groups, key informant interviews. And the reality on the ground and what women really wanted to hear, as opposed to what they were being told, if anything, was quite different. And so I think, you know, the social sciences piece and storytelling of what we do is incredibly important, and we kind of sometimes forget it. So the qualitative work tells the story behind the quantitative numbers. Thanks.
Very good. Let's see, it looks so Dr. Martin says yes, thumbs up. Bisola's applauding. Do we have any other comments or suggestions? This is a very practical one. I put it in the chats a while back. The idea was raised that we need a global champion or global ambassador for surgery at WHO. It was enormously effective that the president of the United States George W. Bush put his weight behind PEPFAR. Do we know of anyone who could put their weight behind global surgery in this way to help coalesce and focus some of our efforts? Something to think about if names don't immediately pop to mind. I was wondering if anyone is associated with the group called the Elders, the past president's organization, people who are meant to just be looking after the global good. If you know one of these people, a past president of a nation, let us know and we'll talk with them about it. Looks like Keith, your hand is up.
Yeah, thanks, Gail. Just quickly on that, former Prime Minister Clark from New Zealand, I think she's now an elder, and she's really engaged with all of the work that we're doing. So she'd be a fairly easy person to reach out to, and she's just right in there. She's fantastic. So nothing speaks louder than money to your challenge, Gail. So I think that what we need to do is we need to engage the big funders, because they need to alter what they're funding. And I think they need to reorient some of their funding towards the work that we're talking about here. That's going to move things forward. And finally, on the chat, I put forward, we ran 2 webinars, one with Dr. Cecilia Wancombo and colleagues on exactly what was asked about building LMIC collaborations, what's needed, how to do it. So that was one. And then we did another one with our colleagues at the African Forum for Research and Education Health with Dr. Elsie Kuguli Malawadi, who's the president. I also put that on. So both the session we held with AfriHealth and the one we held with Dr. Siwan Kambo and his colleagues both speak to the issue of how to strengthen LMIC collaborations. And I think if we can go towards funders and align and help our colleagues in LMIC institutions who are willing to do that, we can work with them to drive funds to them to strengthen that. Maybe that's something that would be welcome if that's what they want. But if we can bring the money to the action, then I think that might be something that would be good. And if Dr. Siwan Kambo's on, if he maybe guides us on this, that would be fantastic, because he was wonderful on the session that I put into the chat. And please share it and look at it widely. Thank you.
Wonderful. Thank you. Is he on? If so, we could put a spotlight on him and allow him to respond. I don't know if he's still on. But there's been a lot of conversation about the ability of people who are on this call and those we represent to be to better recognize the power that we have, and that is a really wonderful thing. Keith, you want to bring up another issue before we close?
Yeah, I just have, while we have Keith Martin with us,
yes,
to us, by the way, maybe I could ask him and put some guidance. You've been involved with, the CUGH and the global surgery satellite dates, and now with the webinar that we're doing now. What are your thoughts about any future events at CUGH involving surgery? Having discussed what we did last couple of hours, what would be sort of a good theme or an event that is different than usual, right? Yeah. Oh, you're muted.
Yeah, no, thanks, Keith, for the question. And thanks for your leadership and yours and John's at Harvard. Really, you've been absolutely outstanding. And Gail, it's always lovely to have G4 work with us as we have for many years. And thank you for that. And also just a shout out to the colleagues at the University of Utah, Dr. DeVries and Dr. Price and others. They've been just so wonderful right from the beginning. So I think just from our perspective, what we'd love to do is we're going to be in Los Angeles next year. And as we sort of put our heads together, let's see how we can bring some of the actors who are not here to the table. And we can do this in various ways. I mean, the public events are there, right, which are good, but let's see how we can be really deliberative and focused. Which countries, and for those of our colleagues who are from Sub-Saharan Africa, if you can, or from around the world, if you can share, if you know if your government is interested in actually dealing with this and want to reach out, let's see how we can invite some of those key actors and governments to the table. Let's also bring the funders to the table. Let's use our conference in Los Angeles to bring money, people, politics, and all of you as experts to the table. And we can do it in a closed, session room to roll up our sleeves. Let's focus on some concrete actions that we can all come to ground on. And then I think, so I'm using that as sort of a point. But I say to, the conference is a moment in time, but we have 365 days between them, right? So let's just think at that meeting how we can have some other smaller sessions we can work on regularly to advance things forward, so we can be focused on what we're doing, have outcomes we seek, have a work plan, but I think that the conference way to face to roll up our sleeves and say, let's focus on a couple of things we can do and let's move forward on those, so we're actually going to see some outcomes. Because I think if our tendency is to look at globally, but the rubber hits the road within countries, right? That's where the action is. It's not around the world. Nice guidance, but let's focus on some very specific actions we can mobilize and pool our assets together with those countries that are interested in building the surgical ecosystem.
Yeah.
And we can focus on some really concrete things, and bring in the public health folks and all the other groups you mentioned here. But let's use the conference for that. Yeah,
that is a really nice invitation. And I'll say on behalf of G4 Alliance, we accept. We're better together. We know this. We're stronger together. And so the differentiation between global health and global surgery has to end. And it seems to me that you've just, issued an invitation that, will be the beginning of the end of people thinking about surgery separately from health. It can't be. We know that it can't be. So on behalf of the G4 Alliance, I'll say thank you. We accept, and we will do all we can to make the CUGH meeting a home for all of global health and surgery, and we'll bring our opportunities, our context to bear at that meeting. So thank you.
So Gail, should I wrap up?
I think we can.
Yeah.
There's nothing kinder than giving people a gift of time. 15 minutes for a bio break and another cup of coffee before their next meeting. Thank you, Keith.
So Gail, thank you for co-moderating in G4. I want to do a special shout out for Radzi Hamza and Natalie Sheneman. They've done some tremendous work in the background. So thank you. Thanks to all the panelists and all the participants. So this is a great, this was a great session for me. It was really enlightening. And like I said from the beginning, we want to get this right? The main theme that I got of it was partnerships and collaboration and how we need to enlarge that network, right? Not just national and regional stakeholders, but also co-creating with them. The surgical ecosystem includes more than just the workforce, biomedical engineering. We have to think about the other aspects. Collaborating with the disease groups, right? That's something that we haven't done a very good job of. Private sector, I think that's sort of our next frontier. We really got to work our way and talk the language of the finance people. And so let's work on this together. I feel like we have some direction. And thank you, everybody, for a great session once again.
Yeah.
Have a great day. Yeah.
Thank you all.
Thanks.